Today I'm joined by Dr Lynsey Hayward, a urogynaecologist guiding women through the complexities of the perimenopause, including navigating concerns like prolapse, sexual function, the pelvic floor, and urinary incontinence. Urinary incontinence is a common yet taboo issue among women, especially in midlife. Many find it embarrassing to talk about even to their doctor, but today we're breaking down those barriers. So what exactly is it? Does childbirth have an impact? How can it affect your sex life? What do treatment options like pelvic floor therapy, lifestyle adjustments, or surgical interventions look like? And what might be right for you? Let's get into it. Lynsey, welcome to the podcast. Thank you for joining me. I wonder whether you could introduce yourself to our audience and tell them a little bit about who you are and how you've ended up having the interest that you do.
Sure. So my name's Lynsey Hayward and I'm a gynaecologist working in Auckland, originally from the UK. I think my passion built up over the years. First of all, my grandmother had severe urinary incontinence, and it was quite impactful for me seeing the alteration in her quality of life, suffering with that and trying to seek treatment, and the sort of embarrassment trying to hide the issue from the rest of the family. And I guess that thought was in my mind as I went through training, and I sort of stumbled across obs and gynae, really. I did a degree in biology and geography first and thought I'd go into parasitology, but anyway, it wasn't to be. And the passion for my job is really making a difference to women's quality of life, because this is a subject that's unfortunately not talked about, but is very much felt by a huge number of women. 1 in 9 will have surgery for prolapse, and about a third will have issues with urinary incontinence. And a lot of them won't share it with family, not even their husbands, their children, and they make their lives smaller because of it. So it's a passion for me to try and help them and give them freedom and confidence back in their life. I love what I do.
Yeah, amazing. So, Lynsey, talk to me a little bit about what actually is urinary incontinence, because I think that some people get a little bit confused as to what we actually mean by that term.
So it's any form of leakage of urine, and then you can divide that up into different types. So stress urinary incontinence is leaking with coughing, sneezing, laughing, jumping, worrying about doing the star jumps when you're at the gym, that sort of thing. Urge incontinence is more worrying for a lot of women in that it's very unpredictable. So you could be sitting in the middle of a meeting and suddenly have a huge urge to go to the toilet that you couldn't suppress and you start leaking. Sometimes that leaks a little bit and sometimes it's an awful lot, so it's running down your legs. So a lot of women don't have it to that extreme, but they might be very familiar with the concept of driving into the driveway or putting the key in the front door and get this desperate urge to go, make way, take me to the loo, let me get to the loo. So that's urge incontinence. And then a lot of people have a mix of both. Stress incontinence is more common when we're younger, under the age of 50-ish, and then urgency as we age becomes more common. Mixed incontinence, a mix of both of those symptoms, more common even as we're even older. And then there's a form of functional incontinence. So if you've got a disability, if you're walking with a walker and it's difficult for you to get to the toilet, you may not have a problem with the nerves that are controlling the bladder or with the sort of mechanical effect that you get with stress incontinence. You've actually it takes you too long to get to the loo and you just cannot hold on.
So it's a mobility issue?
Mobility issue, yeah.
Okay. So can we talk a little bit about stress incontinence first?
Sure.
And that tends to be that younger age group. I definitely have patients who I see who, to be honest, are even in their 20s and 30s
Absolutely.
who have stress incontinence. They are so embarrassed. They're so self-conscious about it. They're quite teary whenever you actually do kind of get it out of them that it's an issue. But what is the cause?
For some women, there's not an obvious cause. So you can be a woman without having children or having had a cesarean and still have stress incontinence. But for the majority of women, it begins with childbirth. So when we give birth, the fetal head has to pass through the pelvic floor muscles And they really have to stretch a lot, to about 3 times their normal length, to give birth. And that means that 15% of women giving birth just with a normal vaginal delivery or a ventouse delivery will get injury to the pelvic floor that unfortunately we can't restore or fix. And up to 50% of women having a forceps delivery. So there's a mechanical, functional issue with our pelvic floor muscles. And although we can strengthen them, if the muscles are partly injured, it's difficult to get full strength back. Then there's a little ligament, which is something that's a bit of a technical term, but imagine a little loop that hooks under the tube that you pass urine through, and that holds it up. And if that little loop is damaged with childbirth, it means that the tube you pee through can flex and bend more than it should, so that our ability to grip and prevent urine leakage is reduced. On top of that, things like being a little bit overweight will put a mechanical pressure onto the bladder. And then there are things like jumping on a trampoline. A lot of women dread jumping on the trampoline. And then it's just a physical force due to the exercise we're doing that overcomes the normal mechanism.
So do we have kind of an inherent design flaw?
It depends. I don't suppose when we were living in a cave we thought about jumping on a trampoline. But if you take an 18-year-old elite gymnast, a lot of them will have issues with leakage. It's just not talked about. So yes, a design flaw, or maybe we're trying to overcome nature.
And so what is the management of someone with stress incontinence? So if anyone listening has this, what would you suggest they do?
Don't just put up with a pad. Number one, I get quite irate looking at the adverts on TV that seem to say leakage is normal, put up with it, you've had children, this is your lot, this is kind of what you deserve. First thing to do is find yourself an experienced pelvic floor physiotherapist who specializes in women's health. And about 70% of women can improve or cure their leakage issue. For some women, they have worsening problems, or the physiotherapy doesn't help them as much as they would like. And then you need to go on to think about surgical options.
And what kind of surgery can you do for this?
So they vary in their invasiveness. The least invasive is one called a bulking agent. The common one that we use around here is Bulkamid. And that's a day-stay procedure, sometimes done under local anesthetic, where 4 little injections of the same sort of filler that you'd use in your face are used around the bladder neck as it leaves the bladder. And these form little cushions that narrow the outlet and stop leakage. The efficacy is about 60 to 70%. It's probably not great for women who've got severe leakage. So women who have a more occasional and inconvenient lighter leakage, it works better for them.
And a bit like filler in your face will need replaced every couple of years. Do you need to repeat that procedure, or does that kind of hang around?
35% of women have a second injection to make the continence as good as it can be. We don't have really good long-term data, 5 or 10 years down the track. The type of filler that's used is fairly stable, but probably does reduce in volume over time. So yes, it might need to be repeated or a different procedure done.
And then if that wasn't an option or that didn't work, what would you do?
If that didn't work, the next least invasive and most effective procedure is a retropubic midurethral sling. And that's a sling made of a mesh material, which I know has been rather controversial in the press. But if you compare a midurethral sling to mesh used in the vagina, it's a very different thing with a different risk profile. I won't go into it. But it's a procedure that's used worldwide as a first-line procedure. And that, again, is usually a day-stay procedure. And that little loop that I was talking about that supports under the urethra, we use a similar thing, but in a woven form that's permanent. And we make a little cut in the vagina, 2 little cuts above the pubic bone area, and that slings underneath. And it remains relatively still. And then if you cough and you sneeze and you jump and there's a downwards pressure, that sort of, if you like, pinches off the tube you pee through to stop the leak. And how well does it work? About 80 to 90% of women are dry with that. About 5% get a new urge symptoms, so needing to go to the toilet urgently, and about 50% of women get an improvement if they get urge symptoms.
Right, okay. So, Lynsey, talk to me about what it would mean for the women that you see pre-surgery and what their lives are like after surgery.
So, for the vast majority of women, it's a huge improvement. It's a very pervasive thing, having urinary incontinence. It's humiliating. It saps your well-being. It can socially isolate you. It can cost you a lot of money with the cost of pads. Women are reluctant to be intimate with their husbands because they're worried about leaking with intercourse, or they're worried about smell and that sort of thing. So it gives women back their sense of well-being. It restores their confidence in their bodies, and it allows them to do the things they want to do. We shouldn't be denied exercise or enjoying time with our family because we're concerned about leakage. It's not fair.
Yeah, absolutely. So is there anything that you can do to prevent yourself from getting stress incontinence?
Keeping up your pelvic floor exercises. So pelvic floor muscles are a muscle you can exercise just like your arms or your legs. It's quite a difficult thing to do on your own. So the tips I would have to make sure that you're doing it roughly in the right way is, if you're having a pee, try and slow or stop your urine down. Or if you think you're going to pass gas, cling on for dear life. And those are the right muscles to practice with. Sure.
Okay.
Some people have such tight muscles. If you're a gym bunny, your muscles might be so tight that they won't relax. So for some women, they actually have to learn to relax their muscles so that they can contract their muscles.
Okay. And so let's talk then about the other type of urinary incontinence, the urgency. Yeah, the urge incontinence.
So the urge incontinence, and often they're in combination, again, first line physiotherapy. Physiotherapy in a lot of trials is equivalent to taking the medications that have quite significant side effects. So always go to the physio first. It might be worthwhile keeping a bladder diary, and there's lots of bladder diaries you can download. If you go to yourpelvicfloor.org, there'll be a bladder diary there. Make sure you're not drinking too much is number one. I see so many women who go to the gym and they're drinking 3 and 4 litres a day. On average, you need 20 to 30 mils per kilo of fluid in the food you drink and food you eat and the fluid that you drink. So don't overdrink, because then, of course, your bladder will fill up super quickly and you'll be peeing all the time or busting to go. So that's number one. Check your fluid intake. Check your intake of things like caffeinated drinks and aspartame, like the artificial sweeteners. Those things can be irritants, alcohol as well. If you've done those simple things, get yourself to a physiotherapist who will train your bladder and give you the confidence back and teach you urge suppression techniques. And then if that doesn't work, we'll go on to the next line, which is medications. The traditional one is called an antimuscarinic, and it has side effects, unfortunately, making your mouth rather dry and can give you constipation. And then there's a newer one called mirabegron that works in a slightly different way. But they're neither of them great. So 30 to 40% of people don't get a positive effect with these, and 50 to 60% of people give up after a year because of side effects. So stick with the physio would be my first thing. That's your second line. Then after that, we can use Botox in the bladder as an outpatient procedure that works really well for about 80% of women, 60 to 80% of women. And then the absolute last line for women with really severe intractable problems would be a pacemaker to the bladder. That again works quite well. It's an implantable device, and that also works for fecal incontinence, but unfortunately not both together.
So it only helps you with one or the other?
One or the other.
Can you have two?
You can't. No, you can't.
Okay. And so if you had someone who was struggling with a mixed bag of stress and urge incontinence, is there one that they should be trying to address first, or does it not really matter?
It's their predominant symptom.
Right.
So women I see very clearly have stress incontinence, And some women very clearly, urgency is their main thing. And they get, if they have COVID and they have a really bad cough, they get the occasional leak. But by far and away, it's that latchkey incontinence where they're hopping at the door or they're turning on the shower. So asking about their predominant symptom, focusing on that, and then addressing the other.
Lynsey, what about the habit that lots of women have, which is what I call the just in case way? So they go to the toilet just in case.
Just in case voiding.
And do you consider that is a contributor to the problem, or do you think that's an okay thing to do?
It's a contributor to the problem, and it underlines the fact that they have a concern about their bladder and they lack confidence with it. An average pee is about 300 mils. And when we do these bladder diaries, if we see women peeing 15 times a day, 100 mils or 160 mils, something like that, then you know that they are responding to the very first urge that they get, that their bladder is filling up a little bit. And it gets them worried because they might have had an issue with leakage before. And then they're responding to that as a sort of security measure. So part of having physiotherapy will be to get people out of that habit. But otherwise, don't make it to the shopping mall and then beeline for the toilet.
If you don't need to go. And what about double voiding? Is that something that people should be doing where you have a wee and then you make sure that you're emptying your bladder?
So as we age, our bladder muscle may not be as strong as it used to be. So you may find that your urine flows a bit slower. And this can also occur with people with prolapse and fibroids and that sort of thing, where they've got an obstruction of their flow. For those women, just taking a little bit of time, sit on the toilet seat. Do not hover, even if you're in the shopping mall. Sit on the toilet seat, allow your pelvic floor muscle to relax, give yourself a little time to pee. A lot of us pee on the hop, as quickly as we can, and we push down and we hurry up. So if you're somebody who goes to the loo and then stands up and then gets a little bit of a dribble when they're going to wash their hands, sit down, have a wee, wait a second, stand up, sit down, have a little go again, and just do a little at the end to empty the last bit.
Okay. Yeah. And another thing that's been quite sort of topical recently is people using like these poo stools where they pop their feet up on little stools that change the angle that you're sitting, etc. What do you think about those? Do they have any impact on bladder, or are they very much more about constipation and opening up the bowel?
Well, constipation can affect bladder function. So if you're very constipated, it can worsen your bladder symptoms. The squatty potty, yes, really good, really good. We should all squat to poo.
Yes.
Because it opens up our pelvic floor and it relaxes our pelvic floor. But we're all too posh to do that. And I know people who are in some of the retirement homes, they put in very high toilets. And they're probably a group that also suffer more with constipation. Yes, so if you can sit with your knees above the level of your hips, then that's good.
Right.
And relax your tummy.
Okay. For many years in my GP rooms and with friends and family, I heard the same story. People feeling overwhelmed with a huge array of skincare products on the market. Fears around having sensitive skin, choosing the wrong product, or being sold something they don't need. There are so many people intrigued by the latest trends in anti-aging treatments, but unsure if that would be relevant or actually even help them. And many are feeling afraid of being left looking different, silly, or even having an adverse reaction. As a doctor of 25 years, and of course as a woman experiencing the signs of aging myself, I am proud to have created You by Dr. Shauna Watts clinics. Led by myself and an experienced team of doctors, our goal is not to change you, just help you become the most confident version of you. Every journey at our clinic begins with a comprehensive assessment by our doctors and includes photography, skin analysis, a thorough exploration of your medical history, and of course, time to chat about your concerns and desires. Together, we create a completely customized plan, helping you achieve the confidence that you've always wanted. We treat all skin concerns, including redness, acne, pigmentation, sun damage, and all signs of aging. We take a holistic approach and only include evidence-based therapies. So if you're ready to start prioritizing you and exploring what we can do to help, please book in for a no-pressure Planning Your Aesthetic Journey appointment. You will leave with a full written plan and information on any recommendations. Our clinics are based at Foresters Beach and Newcastle, and you can book online at youbydrshaunawatts.com.au. So obviously we're here at International Menopause Society, and I'd love to talk to what is the intersection or interplay of menopause and the perimenopause in these bladder issues that we're seeing.
So when we're growing in the uterus, not only is the vagina growing, but also the lower part of the bladder and the tube you pee through. And that's all got a common origin, and it's all affected by estrogen. With the menopause, what you find is that the sort of nice quilty lining that closes off the bladder is thinned, and then the little tube you pee through is thinned, and you're more likely to get issues with leakage. You also get a change in the type of bacteria that grow in the bladder, and you're more likely to get a urinary tract infection, and that can cause irritation. Unfortunately, as we age, we also get a thinning of our pelvic floor and a loss of elasticity and a loss of strength of the pelvic floor. So all those combine together to increase our risk of urinary incontinence.
Okay. And so what can we do about that? Specifically, is using vaginal hormones beneficial to, and how do they go from the vagina to the urethra and the bladder and help?
So in the vagina, the urethra, the lower part of the bladder and the urethra, there's little receptors, and they're all waiting eagerly to receive some estrogen. And they get a bit sad if they're waiting too long, and that means that the amount of blood vessels around the vagina becomes less. The amount of blood vessels around the tube you pee through becomes less. It gets thin, it gets pale, it gets dry, it gets sore. If you give it estrogen, it's like fertilizing the garden, and it all comes into bloom again, and the right bacteria come back, and the tube from the bladder can close off more effectively. Interestingly, taking MHT, oral estrogens, are not that great, or progesterones. They can actually worsen symptoms of urinary incontinence in studies that have been done on large scales, whereas vaginally placed estrogens are beneficial.
And I think the thing that sometimes maybe some of the listeners won't quite know is that actually urinary tract infections can be fatal. They often are in older women. They get urosepsis and end up in hospital. They get delirium, and it can be sort of the beginning of a really downward spiral.
Yeah.
And so that we are talking about something that's really quite significant. And it's not just, it's a bit of a UTI or a bit of an inconvenience. It can actually be life or death.
And the other concern I have is if women are put on lots of courses of antibiotics, it upsets their microbiome. It gives them a risk of getting resistance to antibiotics. So if a woman does get a lot of problems with UTIs, number one, vaginal estrogen cream. Number two, try a non-antibiotic, something like Hiprex. D-mannose cranberry is a little bit controversial as to which types will work, so I would probably steer away from that. Hiprex, which in New Zealand is prescribed, but I think here you can get it over the counter, is equivalent to long-term low-dose antibiotics to prevent urinary tract infections.
In terms of, again, is that something that you would start and stay on for the rest of your life? Or
if you have a proven urinary tract infection, you might want to take the Hiprex. If it's just one-off, you might want to take it for, say, 3 weeks. It helps to reduce the symptoms, because even if you've had antibiotics, your bladder is quite inflamed because the bacteria damage the lining of the bladder. We also know now that some little bacteria will remain under the lining of the bladder, forming little colonies and waiting to come out in the dark and recolonize and cause issues again. So if you have something like the Hiprex for a length of time, it will prevent that. If you're somebody who only gets it after you've had intercourse, I suggest that people just have it by the bed, take one on the night of action and for a couple of days after.
And do we know why do we get urinary tract infections or cystitis after intercourse?
If things are a bit dry, you get microtrauma, and the bacterium can get into this vulnerable thing and ascend in the urinary tract. If the sort of mechanics, if that little tube is not more tightly closed or sealed because it's thinned out, the bacteria can get up more. And we know that the lactobacilli, which are protective against infections after the menopause, are reduced. So the balance of the bacteria is out of whack, if you like. So you're more likely to get more of these bad bacteria, for want of a better word, like E. coli, pathogenic E. coli.
And in terms of vaginal hormones, we know that helps those lactobacilli feel more at home again, basically, and for them to flourish and be protective. If you had, let's say, a 70-year-old female who came to see you with recurrent urinary tract infections, she'd never been on systemic hormones, she'd never been on vaginal hormones, would you suggest starting her on vaginal hormones?
Definitely.
Yeah. And is there any patient that you can think of that you wouldn't put on vaginal hormones?
If you look at the sort of latest guidelines, virtually none. Okay, so women who have had a history of breast cancer are at no increased risk of recurrence taking vaginal estrogen. If you look inside the pack, the sort of writing inside the pack is pretty scary and it puts people off. But if you look at the vast literature on the subject, there's virtually nobody. Somebody with active vaginal postmenopausal bleeding, maybe somebody who's on chemotherapy, I would consult, but I have never been refused it when I've double-checked, if you like. So virtually nobody. It's a very rare case indeed that you couldn't.
Okay. And can we talk a little bit about prolapse?
Absolutely.
What is it? Because there seems, again, to be lots of confusion as to what that even means and who gets it and what can we do about it?
Sure. We've got inside the vagina is lined by walls. Behind the front wall of the vagina sits the bladder. Behind the back wall of the vagina sits the bowel. And in between it is a strengthening wall called fascia. That's a bit like the white stuff you'd cut off stewing steak. It's tough, but it can get damaged. The womb sits at the top of the vagina, and if you imagine a skeleton, there's a big hole there, and the poor old uterus is suspended by guy ropes over that hole. So if we think about the womb, if those guy ropes get stretched, then the womb can descend down into the vagina and even become totally out of the vagina. If we think about the front wall, if you get a weakening of the front wall, then what you see is a sort of squishy bulge, particularly if you're standing up or you've done a lot of gardening. And that squishy bulge is the vaginal skin with the bladder behind it. And then if you go the other way, if you're about to do a number 2 and you can feel a bulge coming through the vagina, that will be a weakening of that support wall between the bowel and the vagina, and the bowel is able to push forward, and then you can feel that. Some women get a prolapse of 1, some get 2, some get a prolapse of all these things that I've described. And there are different stages of prolapse. So the more babies we have, the more likely you are to get a prolapse if you've had a vaginal birth and a cesarean section is protective but not fully. If you're a woman who is smoking, or if you're a woman who's significantly struggling with weight, or you've had an injury to your pelvic floor, then you're more likely to get a prolapse. If you have a job where you're stacking shelves and you're doing heavy lifting, or you're chronically constipated, you're more likely to get it. But 50% of women who've had children get a little bit of, for want of a better word, laxity, where we've stretched a little bit, just like all the rest of us, the skin off face, our tummies are never quite the same. It's the same in the vagina. It does not matter. But if the prolapse comes down to basically level with the hymen, that's the entrance to the vagina, we begin to feel it. If it goes beyond that, you can get issues with difficulty doing a number 2. You might have to splint or put your finger inside the vagina to start yourself off. Or if it's your bladder, you might find that your urine flow is slowed, you don't feel like you're emptying well, it's okay in the morning, but by the end of the day, it's difficult. And if your womb is coming down, then you might think, why can't I use a tampon anymore? Why does it keep slipping south? Or you might actually notice something at the entrance to your vagina that feels like the end of your nose, and that's the cervix coming down. And then in the most extreme, the whole lot is completely out. A lot of people come to me terrified that this is going to happen all of a sudden overnight. This is glacial creep, okay? So it's slowly, so don't worry, it will happen slowly. Go about your daily life, seek some help, get somebody to check, but don't stop doing everything because you found it.
And so what would you do if someone had a prolapse? Is it too late at that point for physiotherapy to be of benefit? Or
if you've got a very early stage of prolapse, so it's there's 4 stages. If your prolapse is still within the vagina and never comes out, then physiotherapy can be helpful. But if it's got beyond that, then normally you might want to consider, if you're older or if your family is incomplete or you don't like the thought of surgery, you might want to consider a pessary, which is a soft silicone ring, or there's various shapes, but generally it's a ring that sits behind the cervix or the top of the vagina if you've had a hysterectomy, and behind the pubic bone, and holds things up. It's not for everybody. About 50% of people have trouble and then end up thinking about having surgery. Okay, so we do know, we've done a study at our unit in Auckland looking at how easy it is to do pelvic floor physio before and after surgery. And if the bulge is out of the way, it makes sense. It's easier to do a squeeze if you're not having to lift something up.
Yeah, okay. And in terms of, again, preventative, is there anything that you can do to prevent this happening?
Yes. Do your pelvic floor exercises. Don't go crazy at the gym, okay? Do not do grip classes or lunges with 50-kilo weights. Look after your bowels. Take the time to go to the loo. Don't get constipated. I honestly have patients who spend an hour trying to make themselves go to the loo each day. You know, eat enough fiber. Go to the loo when you need to go. Don't defer it. Use your squatty potty. All of those things. If you are in a job where you're doing heavy lifting, try and lift 10 to 15 kilos. Engage your pelvic floor, not just your core. Okay, so get your pelvic floor so you're resisting that pressure build up in your tummy.
Lynsey, tell me what it would be 1 or 2 things that you would love people to know about urinary incontinence that might help someone listening to do something about it.
You are not alone. Okay, be brave. Make an appointment with your doctor to discuss it. But don't make the appointment along with 3 other things. Do a bit of reading, yourpelvicfloor.org. There's a lot of information there, and there's patient stories. And have courage that if you were sitting in a room of 30 people, 30 women who'd have kids, I can guarantee 10 of them would have your same story. It's just not talked about, which is a tragedy. So be brave, go and seek some help, and don't put up with it. And don't feel that you're irrelevant. A lot of the time we're looking after our aged parents or our teenage kids or the husband, and we never make time for ourselves. So make a bit of time to improve your own quality of life.
Great advice. Is there anything else that you would like to mention that we haven't talked about today?
A lot of women have fecal incontinence, which is even more sort of taboo than urinary incontinence. So 13% of adult women have issues with fecal incontinence. So if that's a problem for you, also go and mention that. If you do have that problem, being a little more constipated rather than having looser bowel motions is probably the number one thing that's helpful for you.
Okay. And what specialist would they go and see for that? Would that be a gastroenterologist, or who would you see if you had fecal incontinence?
A colorectal specialist probably. But if you've got problems, digestive issues, then a gastroenterologist, like if you've got IBS symptoms, a gastroenterologist will be able to help you to manage that.
Okay, amazing. Can we expect that if we have a patient and we have them on systemic HRT, that we would potentially see some benefits for things like urgency?
Actually, not particularly. You're better off having vaginal HRT. The sort of studies that have been done have shown that the symptoms tend to worse. They lumped urinary incontinence together. So no, vaginal is better, but yeah.
Okay, perfect. Lynsey, thank you so much. You have been so generous with your knowledge. I ask everyone who comes on the podcast the same final question, which is, if you could give a piece of advice to your 20-something self, what would you say to 20-something-year-old Lynsey?
Ask your mum if she's got any issues with her pelvic floor and be her mentor and guide and encourage her to go and seek help.
Thank you. Thank you so much. A quick note before we carry on. There are many other non-mesh options available to treat urinary incontinence that we didn't address in this conversation. Surgery may be needed if conservative measures fail. Please seek medical advice from your doctor. When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.